prevalence. So there is this study that just came out, that there was a sneak preview of this study last year on the CDC website. And what they did was they did a survey between March and June of folks that were already enrolled in a different study. And they asked them about their mental health burden. And what they found that over 40% reported having symptoms of depression and or anxiety, and they lumped them together. Really distressingly, about 11% reported serious suicide ideation in the past 30 days. And this was especially true if the respondent was somebody who was a younger adult, if they were a racial ethnic minority, if they're an essential worker, or if they were unpaid adult caregivers, that is relatives and friends who are taking care of somebody with a chronic condition. The common risk factors for depression are age. The middle age group and the younger folks actually tend to be at a higher risk. There is this idea that there's an older, sort of the geriatric depression, but depression seems to kind of have this bimodal distribution where at a certain age, the risk goes down until it goes back up again. I already mentioned that women are at a higher risk than men for depression. People who've had a previous episode of depression, a history of other mental illness, history of a substance use disorder, such as alcohol use disorder or any illicit drug use, are at high risk for depression. If there's a family history of depression or suicide, it seems to be a risk factor. So there seems to be at least some genetic loading as well as some loading around the nature nurture argument. Having a chronic medical condition increases the risk for having depression and depressive symptoms. And then there's social factors that contribute, such as unemployment, poor social support networks, recent stressful events, and intimate partner violence. And I should just preface this by saying that we're happy to make the slides available to you. So if there's information in here and the references that we're happy to share those. Given that a lot of you are representing various specialties, I think it's important to recognize that depression is frequently comorbid with many medical conditions. At the bottom is what Dr. Gupta just started off sharing, that about approximately 30% of people with neurological conditions have comorbid depression. But there's other common conditions such as end-stage renal disease, COPD, heart failure, hypertension, diabetes, and coronary artery disease that also have common comorbidities with depression. And these estimates tend to be from clinically significant depression. But if you look at depressive symptomatology, one of my areas of specialty is heart failure. And it is estimated that anywhere from 40 to 70% of people who have heart failure experience at least some depressive symptoms, even if they do not meet the criteria for a clinical diagnosis. But that's not all. It's probably not surprising that clinical depression is also comorbid with other mental health conditions. So this is a study we did a few years ago at the VA. So one of my positions at the VA Palo Alto healthcare system. And you can see that depression is comorbid with PTSD, which is this bubble in veterans. Almost 50% of people with PTSD have depression. Almost 55% of people with anxiety have depression. So you can see that these conditions are very comorbid. So it's not that if you have depression, you're at lower risk for other mental health conditions. They may pile up. And the kicker of that is that the more mental health conditions you have, the worse your outcomes. So in another study we did after that, we found that certain combinations with depression were particularly deadly. So this is a 10-year time frame of following about 10 million veterans. And what we found is that across this 10-year period, which is 2002 to 2011, we found that the highest rates of death were in this group that had depression, substance use disorder, and serious mental illness like bipolar and schizophrenia. So this is not meant to kind of be a research talk, but it's just to illustrate that depression not only exists very commonly, it exists commonly with other mental health conditions. And the combination of depression and other mental health conditions amplifies the risk factor of poor outcomes, including mortality. Who manages depression? Well, it turns out that the primary care is actually the front line of treatment for treating and assessing depression. So again, in one of our studies, we found that almost 14% of veterans in via primary care had a diagnosis of depression. And one of the models that is commonly used because of that is this idea of integrated primary care, which is defined very broadly in a lot of different ways, but the general idea is to co-locate a mental health expert, whether it's a psychologist or psychiatrist or a psychiatric nurse within primary care to manage depression and other common mental health conditions such as anxiety. In one of our studies, we found that if people got their mental health treatment for depression, especially in primary care settings, so this integrated model, it actually reduced the number of specialty mental health care visits that they needed. So those of you who are in primary care, this is a really important thing to be thinking about is, can you assess and can you triage patients within your healthcare systems or healthcare practice to people who can provide this behavioral and mental health support? But what this means when you look at the comorbidity with mental health conditions, when you look at the comorbidity with other medical conditions, is any healthcare team can expect that they will be assessing and managing depression. So here's a couple of screening tools that are can be really useful. And some of these you may already be familiar with it. The symptom presentation for depression can be both physical and cognitive symptoms. And these are criteria taken from DSM, Diagnostic Statistical Manual, as well as the ICD. I'm not going to go through each of the symptoms, but you can sort of see them and you're probably already familiar with the symptoms. One of the important pieces to realize is that a lot of the work that I just talked about, as well as the work we're going to be talking about in terms of management and screening, is based on predominantly white populations in the West. So when you think of people like us, people who are of Indian origin, South Asians, there's a lot of cultural differences in how depression is both expressed as well as people, how they might respond to the different treatments. So for instance, there's a fair bit of evidence showing that Asians, the whole Asian group, and that includes South Asians, are more likely to present depression as a somatic symptom. So they may talk about pain, especially back pain or headache, and they might actually talk in terms of, or stomach upset and things like that, because there's often not a language or a culture around expressing the kind of sadness that goes with depression. So there's not a lot of spectrum of going, how do you express depressive symptoms? What that also means is that a lot of the treatments we undertake, which is cognitive based, is based on the thoughts that people might have around their depression. And so you have to think about how best could we manage people who are expressing more somatic symptoms of depression, and how do we approach them so that they get good culturally concordant care. Another good example is that men are more likely to express irritability and anger when they're depressed as opposed to sadness compared to women. So as we're thinking about our own clinical practice, it's important to keep in mind that what we're going to talk about is kind of the evidence base, but there might be some opportunities to think about how we can culturally tailor our approaches. One thing that kind of often comes up is suicide. So I just want to share some statistics. We know that suicide is a 10th leading cause of death in the United States in 2019. And on average, there are 130 people who die by suicide every day. The risk of a suicide, completed suicide, is almost 4 times more than women. Women do have more attempts, but men tend to take more lethal means, such as firearm. So they're more likely to actually die by suicide than women. But one of the important things to think about as you think about your own clinical practice is that we did a study that Simonetti et al. And another group at Kaiser did the study. And we found when we looked at the electronic health records that almost 50% of those who die by suicide do not have a documented mental health condition in their medical records. So the general approach that we take with suicide screening is that we first recognize if they have a mental health condition, and if they have a mental health condition, we sort of further screen them for suicidality. What I would encourage you all to think about in your practice is to screen for suicide anyway, because what we find is actually people may not have a documented mental health condition, but they're at a pretty high risk for dying by suicide. So this is the first screening tool. This is an actual screener. It's called a PHQ-2. It stands for Patient Health Questionnaire. And it was created in the early 90s, literally based on the DSM-4 criteria at the time. And it screens people for two cardinal symptoms of depression. One is anhedonia, which is little interest or pleasure in doing things. And the other is feeling down, depressed, or hopeless. And this is a measure that actually in the VA system is used for every veteran who comes to primary care once a year, or actually at every visit. And if people screen 3 or more on this, then they get the PHQ-9, which is the full 9 symptom measure for screening for depression. So this covers, in the last 2 weeks, have people had anhedonia, feeling depressed or hopeless, which are the 2 items I just mentioned, as well as some of the somatic and other cognitive symptoms. Item 9, which is the last one, is the item that is specifically screens for suicide. And a lot of people recommend that if you're going to give the PHQ-9, to further investigate if people score anything more than a 0 on that one. There are 2 approaches to management, broadly speaking. One is the behavioral approaches, and people can be provided behavioral approaches, pharmacological approaches, or both. The Nice guidelines, which are these international guidelines that are created in Nice, France, currently suggest that people undertake behavioral approaches for mild to moderate symptoms, and a combination of behavioral and pharmacological approach for severe symptoms, as well as a combination for chronic or refractory symptoms. But these are just one set of guidelines. And I'd be curious to know if, and when you get to the Q&A, if you have a different approach, because a lot of people have taken a lot of different approaches when they think about how best to manage depression within their own clinical practices. The behavioral approaches can be thought of as low or high intensity. So lower intensity approaches can be carried out by anybody who is trained in a healthcare profession. So these could include sort of guided self-help by means of written materials, so you can provide resources and kind of encourage people to think about their depression, and there's a lot of resources out there. This involves limited professional support, so people may get some support from their primary care provider, for example, once every 6 months or so, or have somebody check in with them every so often. And there's a lot of website-based interventions out there that are self-guided. Higher intensity requires specialized training. So so I'm a clinical psychologist, for example. I have a PhD in clinical and health psychology. And there's another degree called PsyD, which is Doctor of Psychology, who are trained to provide evidence-based psychotherapies. In most states, master's level psychologists are not allowed to practice independently. So master's level psychologists are available, but they're often, they're required in most states to be supervised by a clinical psychologist or a psychiatrist. However, there are masters of counseling that are available who are allowed to treat independently. And then there's other specialties who may also be trained in some of the therapeutic techniques, including psychiatrists, psychiatric nurses, and clinical social workers. When you think about high intensity, you're often thinking psychotherapeutic approaches. And the most common and the one with the most evidence is cognitive behavioral therapy. And the idea behind CBT is that the therapist, the psychotherapist, helps patients replace their non-functional thoughts and behaviors with functional ones. And there's the strongest evidence, and there's some recent work suggesting that CBT is as effective as antidepressants for moderate to severe depression. We also know that medications are often, the efficacy can taper off, but because in CBT or other behavioral approaches, people learn skills, the response tends to take longer than medications, but the changes tend to persist, and this is broadly speaking. There's some newer approaches. One is called acceptance and commitment therapy, which is a mindfulness-based treatment, which has roots in behavioral analyses. And it's new, so there's not as strong evidence as CBT, but there's really strong preliminary evidence, especially among those who have comorbid anxiety with their depression. And then interpersonal psychotherapy is another very common treatment approach, which addresses the social and interpersonal triggers of symptoms. And the way I always think of IPT is when you think of social interpersonal triggers, it sort of sounds really jargony, but we all know people who initially, when they're really depressed around us, we want to kind of reach in and we want to help, but then at some point you start withdrawing because nothing you're doing to provide support is really helping. And so what happens is that slowly over time, their support system starts withdrawing. So then they amplify the depression, the depression gets amplified, which causes people to withdraw even more. So then for that group of people, it's helpful to learn better interpersonal skills that can get people engaged in their life without them having to amp up their depression symptoms. And then there's some other ones that are out there as well. One is mindfulness-based cognitive therapy, which there's some preliminary evidence that it's especially used for relapse prevention, and emotionally focused therapy, which addresses emotions. So with that, I'm going to hand it over to Dr. Gore to talk about pharmacological approaches.
Thank you. That was a really nice talk. I learned something. So I'm going to share my slides. Give me 1 second. So I wanted to thank everyone for taking time. Oh, by the way, I'm disabled on participant screen sharing. So maybe, yeah, I can't share my screen right now. Someone has to allow me. Is that you, Ranak? Oh, it's...
I'm not getting a request. Worst case, I have your slides unless you updated them.
I made some modifications. Give me one.
I just made you a host again.
Okay. Okay. Great. Great. Thank you. Okay. Yes. Just give me 1 second. Just. Right. So I'm going to, I think it could be something related to my own computer. So I apologize. Thank you for being patient. One participant can share screen, and we have, yeah.
There you go. Great.
All right. Just open this. So I'm actually going to briefly talk about the psychopharm or psychopharmacology of certain topics. So for example, I want to make sure that we're going to talk about briefly about depression only in terms of psychotherapy, because the psychotherapy aspect is part of the management of depression. I just wanted to touch on the medications. So if you look at the APA guidelines, and the APA guidelines actually have a very specific format on how to treat depression across ages. And I've given the link. I'm happy to put it in the chat or share my slides or answer questions at the end of the session. So the way to think about it is you have to have shared decision making. So the shared decision making really revolves around the values of the patient, the preferences, and sometimes it is the preference of the provider also, and challenges both structural or perceptual to make that decision on what needs to be done. Now, there are other things that we have to take into consideration, which would be whether we're going to use the SSRIs, which are considered second generation antidepressants, or the SNRIs. I'm just going to admit someone. And then there's the genetics and the drug interactions that are important to consider. Okay. My thing's not moving. All right. And so I've actually broadly touched on what is approved by the FDA for adults. So if you look at the categories, at one point, only everybody would talk about the SSRIs. And I know the SSRIs, all the evidence for use of in a primary care setting or in conjunction with medical conditions is for SSRIs. I want to also sort of talk about one of the newer one. It's called vortioxetine. It is not used as much, but it's relatively newer. And I'm sure some of you all have actually heard of it or even used it. The medications that are popular among the SNRI category would be venlafaxine, duloxetine. Those are used actually quite a bit in primary care settings also. Tricyclics and tetracyclic antidepressants are actually predominantly used in primary care settings rather than in psychiatry. However, there are some antidepressants that are used in psychiatry rather than being used in a primary care setting. The other medications which some of you all may have used would be the atypical antidepressants. So that would be nifazodone, bupropion, mirtazapine, and trazodone. And even though trazodone is one of the antidepressants, in order for it to actually function as an antidepressant, you need to actually use 400 milligrams. And the issue about 400 milligrams is the side effects. So trazodone actually is used more as a sedative, which is not addicting. One of the side effects I want to mention of trazodone is priapism. It's rare, but it is there. And so, thinking about using it in a male patient, but in a female patient, it would be easy. MAO inhibitors are almost rarely used even in psychiatry, but I do want to talk about MSAM, and MSAM is a patch. And so as a result of that, dietary restrictions with MAO inhibitors, are not there. And so this could be used as a patch, and a patch has a value system, especially in individuals who may want to bypass the multiple medical issues they have, or they just prefer. It's a patient preference, to be honest. Also, it's more like for refractory depression. I want to talk about esketamine spray. So this is an NMDA antagonist. It is only used more to augment an antidepressant at this point. And it is not commonly used, but some psychiatrists feel comfortable using it. And then there is an IV antidepressant, which is FDA approved, neuroactive steroid, a GABA A receptor modulator. And I can't imagine too many people using it. So, and in psychiatry also, because we do outpatient practice, as a result of that, we don't really use it. Now, I just want to briefly talk about antidepressants and pregnancy, only because is one of the things which was requested was to, to sort of highlight the antidepressants with regards to pregnancy. So if you look real quickly, you will see that everything is really a C, except Paxil or paroxetine, which is a D. And so because of that, I want to say is the medications that are generally used mostly safely would be the SSRIs, even though all medications are actually used. Again, so going back to the provider preference, because SSRIs are the most studied medications, what we find is that the provider tends to, so all the patients I see, if they have been put on any kind of medication during their pregnancy, it's always an SSRI, never Paxil, but it tends to be, whereas you can see that there's a whole list of medications that, for example, fall in the category C. I want to touch a little bit on the question of, medically compromised individuals, people who are taking more than one medication, and to understand that there are certain specialties, for example, dermatology, psychiatry, and anesthesia, where the medications we use all get predominantly metabolized, with few exceptions, through the liver. And in the liver, there is the P450 system. And I want to say is the P450 system is unique, where sometimes you can predict how the patient is going to actually react to a medication if you have adequate information on their side effects and benefits. So if you look at the inhibitors and the ones that actually really stand out, and this is really not a memorization slide, this is something we have to look at all the time. There are certain, for example, companies that do these genetic testing, so you can get anyone to actually do a saliva test, and they will give you how the variation or the pleomorphism is of these medications. And I had one more slide, which I actually removed because it was a little heavy, but I can give the reference. But it talks about how there are many things, including cigarette smoking, that actually can be inhibitors of these enzyme systems, or some can be inducers or substrates. So I think the neurologists tend to actually use a lot of this, but if you see, there are a whole bunch of mycins on it and other medications. So the ones that really, I want to say, cross over is things like grapefruit, alprazolam, trazodone, or Tegretol, caffeine. And so caffeine, as part of the history taking, is important for when we do history taking for psychiatric medications. So this is a very important slide when you're thinking of, what is going on? Why is it not? I've always used Prozac for this patient. Why is it not working? Am I missing something? Or I've used Luvox, fluvoxamine, etc. And we see that, and I just want to say I am predominantly a child psychiatrist, and I see that a lot in children, where the child has been taking a medication, a year they get put on antibiotics, next thing you know is they're having significant side effects. I want to also kind of touch briefly on renal failure. So I've actually got two categories. So one is actually hemodialysis and end-stage renal disease. So in a review paper, what they found is if with Celexa, 1% of Celexa is removed because of the hemodialysis, whereas fluvoxamine, 23% is removed. So for example, to keep those numbers in mind, because if the patient is on hemodialysis, you have to kind of decrease it accordingly. They also found nifazodone is lowered, but they found that the clinical picture does not change. And they've said that mirtazapine, you need lower doses. Now, that is for patients who are on hemodialysis and what is available out there. Again, it's mostly SSRIs people use. End-stage renal disease. The sertraline, you have to go down low, and they recommend, so sertraline dose comes in 50, 100s. So they recommend that you start with 25 milligrams per day to see in end-stage renal disease. And venlafaxine actually is the amount of venlafaxine available can be reduced also. The thing about SSRIs is the side effects that occur with SSRIs, like nausea, vomiting, diarrhea, and sexual dysfunction, also happen in end-stage renal disease. And so it becomes a little bit confusing on what needs to be done and what is coming after that. So I want to say the recommendation based on that was to do psychotherapy first instead of going to medication. Now I'm going to spend some time talking about delirium versus sundowning. Now, if you think about delirium, it's a disturbance of consciousness, attention, cognition, and perception, but you can also see that it affects sleep, psychomotor activity, and emotions. And I'm sure everybody has seen ICU psychosis. So it just plays a huge role and presents in a different way. So you all see delirium more. We see it mostly in an ICU setting or on the consult service. But I want to talk about sundowning. So it's interesting that, Raj, you asked for this talk where you talked about, can you do the management of delirium, sundowning, and depression? And this is where I really want to help is sometimes dementia presents as, depression can present as sort of like a dementia picture, but it is not. And sundowning commonly can be missed, but it is a very specific term used in patients who have Alzheimer's disease or similar conditions, but it's more seen with Alzheimer's, where during late afternoon or evening, you see a lot of aggression, agitation, delusions, hallucinations, paranoia, increased disorientation, or wandering and pacing about. Those changes you don't see in that person in the daytime. So overall, if you think about this, is the principles of management, is what is the role of the psychiatrist? What are the environmental and supportive interventions? And what are the somatic interventions? So what is the role of the psychiatrist? So when do you call the psychiatrist, right? So the psychiatrist's role is to sort of identify the cause and coordinate with the care team. Then to initiate immediate interventions and ensure the safety of the patient and others. So, when I was at the Cleveland Clinic Foundation, we were part of a team. So a psychiatrist, a pastor, and a security guard were part of what is called the crisis intervention team. So we carried 2 pagers, but what it is once there is a crisis, delirium and agitation, that is a priority because the safety of the patient and others is a priority. Assessing the individual and family psychological and social characteristics that are possibly contributing or taking away, establishing and maintaining a supportive therapeutic stance with the patient, the family, and other clinicians, and also providing post-delirium management to support the patient and family. Now, in terms of supportive management is, optimizing the level of environmental stimulation by making, familiar things, reducing the sensory impairments, providing environmental cues that facilitate orientation. And this could be simply as, where are you, what is the date, and things like that sometimes. And reorienting the patient. So reorienting them, reassuring them. My vivid memory is of a Parkinson patient with dementia who I would spend a few minutes just talking about, that it's going to be okay. It wasn't going to be okay, but just the reassurance was therapeutic. And I really spent 20 minutes. And you don't know what's going on, but you get it from the family member where his daughter said, he only smiles now when he comes to see you. So those are the things you have to understand, that the reassurance is a very powerful tool in them. And also information concerning delirium that may reduce fear or demoralization.
Thank you.
Also informing nursing staff, general medical physicians, and family members of their support. Now, I want to say somatic interventions are, antipsychotics are the drugs of choice. Now, because Haldol has been studied the most, right, is we use a combination of low dose, we can use high dose, and I want to say I can hear someone, so I'm not sure if there's a question being asked of me or, so there's low dose, there's high dose, and then there's IV. So IV is, used mostly in a medical setting, you do have to monitor the EKG for QTCs, and the QTCs is more than 450 milliseconds or more than 25% of their baseline. Sometimes as a combination, we have found 3 milligrams of IV Haldol and 0.5 to 1 milligram of lorazepam. And if you see, the study is from 1986, it is still done today for agitation. We find that low doses of Haldol are used in people with AIDS and HIV and also in the older age group. There are many medications that have come out since then. There's Risperdal, olanzapine, chlorpromazine, and quetiapine. These are also used in different doses. I'm going to stop share now. And I'm going to open it up for sort of questions. Let me check the chat page.
Sonia, do you want me to just finish up or do you want to address, there's a couple of questions for you in the chat.
Yeah, so give me one second.
We should finish the presentation about the study, and then we can have the question answer.
Yeah.
Yep.
So I just wanted to actually sort of, I was talking a little bit about being a child psychiatrist, and one of the things is we use evidence-based studies in the treatment of children. But one of the things is it is very clear that all the evidence-based studies which we use are actually not tested on the South Asian population or any other but white male. And so, keeping that in mind, as I really feel I should emphasize the importance of Ranak or Dr. Trivedi's, research. So I'm just going to have you talk now, and then I can answer the questions at the end.
Okay, that sounds good, Sonia. Thank you so much. I just have a couple more slides. So, this is a really neat tool that I just wanted to share with everybody that I found on BMJ. And it basically, there's an interactive tool that you can click on, and it tells you the different treatment options for different levels of depression. So I put the link in there. Again, the slides can be made available to you. So definitely check it out. I thought it was really great for just kind of learning the kind of work that Sonia and I just talked about. So that's just for your reference. And then to Sonia's point, this is not really depression specific, but we would love to get your help in recruiting for one of our studies in which we are trying to understand the unmet needs of women, South Asian women who are managing breast cancer and their caregivers. So the background of that is I'm a clinical and health psychologist. So a lot of my work is at the intersection of mental health and medical conditions. And I've done a lot of work in serious illnesses like heart failure and COPD, end-stage renal disease, and more recently cancer, with the idea that we need to have a better understanding of how we can better engage family caregivers and other support networks in the overall management of these conditions. And so we were funded by the Cambia Health Foundation to do a study specifically for South Asian women with breast cancer and their caregivers, which we're calling SUFFERED. SUFFERED is, I'm Gujarati, it's a Gujarati word that means succeed, which is a suite of programs that we have created. And the idea is that we want to understand what is it like being South Asian and navigating having breast cancer, and what is it like being a caregiver of this person. And so there's some information on this flyer to the right. I'm gonna ask Dr. Gupta to sort of send it around through an email if you all don't mind. And it's really meant to be a talking with our team to tell us what is it like to have breast cancer, what is it like to have family member with breast cancer. And one of the challenges that we're experiencing is that there's a lot of stigma around cancer. And so we're having a really difficult time convincing people to talk to us because people are feeling pretty isolated is what we expect. So if there's people that please do send them our way. Just contact us through our study information, or they can contact me directly. And we also have, as part of our study, a goal to talk with providers. So if any of you are interested in sharing your thoughts, It's going to be about 30-minute conversation with one of our team members to talk about what is it like in your practice when you're talking with South Asian patients who are managing breast cancer. What kind of resources should we at Stanford make available? And any thoughts you might have is from your experiences with treating South Asian patients, what are some barriers you think we might be experiencing in recruiting for our study? So that's just a plug for some of the work we're doing that is a little bit different from the depression work, but it's related because a lot of the people who are caregivers and patients who are dealing with cancer may be depressed, but they're not getting identified because there's so much stigma around both mental health and cancer within the South Asian community. So with that, I'm actually going to just show you a couple of slides. I'm not going to talk about it, but just there's an interactive screening tool here. And then we put some the websites that you could go for the screeners. And here's some references, and then I'll open it up for questions. And I'm actually going to unshare so that we can sort of see people's faces.
Yeah, thank you very much, Ranak and Sonia. This was great talk. After a long time, I got some refresher course, and I really loved it. So I want to open up the session by asking you a simple question. How do we differentiate major depression from minor depression and then adjustment disorder with depression? These are relative terms, but I think they carry a lot of weight in diagnosis and then how we manage going forward.
Dr. Trivedi, would you like to take, do you want me to? Well, I'm just going to go.
Go for it. Go for it.
So I think when you refer to, so you think of the DSM-5 and how we talk about sort of depression, and then we talk about, we don't call it minor depression, but we can call it something like dysthymia or persistent depressive disorder. And if you think about it and you follow the CIGI caps, so, and I'm just going to kind of put it in the chat page. So if people are not familiar, I can elaborate on it, but so please feel free to chat on that. And so CIGI caps, if they don't meet the criteria for depression, but they have this baseline sort of depressive sort of symptoms, which comes and goes, then we consider that sort of like a persistent depressive disorder or dysthymia. And Dr. Trivedi, feel free to sort of dive in because that's my conceptual.
Yeah, typically I agree with Dr. Gaur. We don't talk about minor depression per se. That's not a criteria, but there are both dysthymia, which they don't meet all the criteria, major depressive disorder. It is a constellation of conditions. So a lot of the work that I sort of set us up in the background, when they talk about depression, they do tend to lump a bunch of conditions together. There are specific criteria in the DSM, and I'm guessing in the ICD as well, which I'm not as familiar with, that talks about which criteria will be used to diagnose different things. Adjustment disorder is very specific to a actual event. Back when I was doing work as part of the CL service, that's something we commonly used because we met people once during their hospital stay after an accident or some health condition. But there is a time limitation after which either it remits or it can go on to, if the symptoms continue beyond a certain point, then it converts into either major depressive disorder or dysthymia. So there's adjustment disorder is not something that can technically stay on somebody's record for a long period of time. Unfortunately, we know how medical records work, so things never just get taken off. So people can have adjustment disorder for years on end, but the diagnostic criteria are very specific to a certain time limit.
Thank you very much. Other question I had was those screening tools you gave us, PH2 and PH9. So we know PH2 more than 3 is significant. What's its number significance for PH9, which help us how to navigate the treatment?
Yeah, it's a good question. I think And I can double check this, so don't hold me to this, but I think that the PHQ-9 recommends 12 or above. So 12 to 15, I believe, is mild depression, and 15 to 17 is moderate, and then so forth. And then beyond that is high, something like that. However, in the health psychology world, in the behavioral medicine world, when you're looking at comorbid medical conditions, so if you have somebody with a neurological condition, Dr. Gupta, in your practice, or with heart failure, you might actually lower the threshold. So in our studies, we often use 10 and above as the criteria because there's because the risk of getting depressive symptoms is high. And so there is an adjustment we make in the research setting. In the clinical practice, it may differ, but I would recommend 10 or above if you're doing specialty care.
Thank you, really helpful.
Mm-hmm.
I think there is some questions in the chat box.
So I actually, while Dr. Trivedi were talking, I was actually, I answered what I think I answered these questions, but I used specific people. I'm assuming I got their name correctly.
Okay. Anybody else has any questions? They can unmute and ask the question.
Yeah. Since Dr. Gaur, this question is for you. I have a lot of younger patients coming in with anxiety and depression, middle schoolers.
Wow.
So since last year, and I use some adolescent tool. That's the questionnaire that I use.
Mm-hmm.
But for them too, is CBT still a better option?
Absolutely. I mean, I want to emphasize that if the therapies are really the thing, CBT is the thing that actually helps them. So middle schoolers don't have developmentally the bandwidth to appreciate a lot of stuff that older age, teenagers have or adults have. And so what happens is the middle schooler just sometimes requires tools and techniques. And if I'm sure all of you have engaged with that particular age, they are challenging. You don't get too much information and you have to be very patient with them. But in general, they do remarkably well with therapy. In the pandemic, there are a lot of patients who come to me and say they got worse during the pandemic. And the thinking in our profession is that the worst is yet to come. This is nothing, but the pandemic, they most probably struggled with something else prior to the pandemic, and to identify that to help them. And sometimes just, referring them for a consult, just to get an opinion is helpful.
Thank you.
Sure.
So there is a dearth of psychologists who will deal with these middle school children in particular.
That's
I
excellent.
think I'm looking, so if there are any resources you can suggest, where can I find, because each insurance company is tied up with a certain number.
Okay, so you are where? Because I know everybody's from everywhere.
I'm in San Jose.
So let me put this, I love this website. Psychologytoday.com is something that is, what you do is, let's say I'm a therapist who's in private practice. I put the details, I put what insurances I will take, what age group and all, and I will tell you also what insurance I do. So I sit down with my patients, because even though I work for Stanford, we do not have therapists, what I help them understand that you can put your zip code, you can put this, and they tell me the more challenging part, right, is actually getting someone who's available. So then during the pandemic, this is our silver lining. Everything is telehealth, right? So I can go to New York and do therapy, or I could go to LA and get my therapy, because it's all online today. And therapists can practice across state lines as opposed to psychiatrists, where we are sort of a little restricted by our licensure.
Dr. Ranak, I will take this opportunity to ask one more very specific question about CBT. We all have some idea, but could you give us some examples? How do we displace the thoughts and how does it work?
Sure. So I can provide a little crash course, and I'm happy to share some resources as well. So the idea of cognitive behavioral therapy is that what gets in the way of our mental health is that we have thoughts and behaviors, both thoughts and actions, that are not fitting what we need to do to maintain our mental health. So for instance, if we have, let me give an example that I often wind up giving to people I mentor, is that people think that they are working towards, let's say, a degree, and they feel they're not good enough, right? So they feel that they have imposter syndrome. I'm stupid. I don't know anything. I've not learned anything. So these are all dysfunctional thoughts. And this kind of thinking is called catastrophic thinking. Or we might think that if we don't have, like now that we are in a pandemic, we're all doomed, right? We're all going to die because COVID is going to infect everybody. We're all going to be dead, everybody, you know. So that's black or white thinking. So there's different ways in which we can express our dysfunctional thinking. And we all do this. It's a very human way of experience. It's not a specific group of people. We're all prone to this at some point or the other. We think, you know, we get a call from a family member and they, you know, just say, call me back. And we're like, oh my gosh, what's going on? Is there bad news? Why didn't they leave me a message? Are they upset with me? Right. And so we kind of we create these realities without having information. What CBT helps with the thought is to say, okay, what is the evidence behind this, for example? So if I say I'm feeling really stupid, I've learned nothing during my program, then so what is the evidence? Well, not a lot of evidence, right? Because you've kind of continued your program, you continued your degree. And so we sort of challenge that thought, challenge the dysfunctional thought to think about, is there an alternate explanation for what you're interpreting in a dysfunctional way? So that's the thought piece. The behavior piece is sort of what do we do once we have that thought is, let's say we're upset with a family, or we assume that a family member is upset with us, right? We may create this reality in our mind that they're upset with me. Maybe it's something I did, but what did I even do? Like they always react like that. And then if we challenge it to say, okay, what's the evidence that this person doesn't care about me? And then you say, okay, what is the alternate explanation? Oh, well, maybe they just had a really bad day, or maybe they're just really tired, or I know they're really hungry. So maybe it's just nothing to do with me at all. It's just who they are right now. And then that gives you a chance to sort of step back and kind of come up with an alternate explanation for what you might be perceiving. The behavior is then what you do with that, right? So behavior in CBT has two ways. There's the basic behavioral activation. So in the context of depression, we get people to start moving. So don't lay on the couch, don't lay in bed all day. Even if it's for 5 minutes, get out and do stuff, you know? So that's a behavioral activation piece. But then the behavior that follows the action is if we think somebody's upset with us and we believe it, we may withdraw from that person. But if we challenge that and we say, maybe that person is not upset with me, maybe let me ask, we might lean in and say, hey, I just saw that when you said that kind of what came out a little rude. Is everything okay? And they might say, oh, I'm so sorry. Like I was just really tired, or I'm really hungry, or they might say, yes, actually, I am upset with you, but let's talk about it, right? So it totally changes how you approach the problem. So that's the C part of the B part. And there's all these different exercises that we kind of get our patients to do. Problem solving is another way of thinking about it. So if we are facing a decision, should I take this job that looks great, but I have to uproot my family? Should I stay in this job that I'm not very happy, but my kids want to stay in high school here? And then, so problem solving is another strategy we might help kind of navigate some of those issues as well. the thing about CBT is it doesn't just address pathology, I guess. It's an approach you can take to address other issues that might be distressing and may help you make some decisions. Dr. Verma just put in the chat, like, we may fake to look happy. There is this strategy we call fake it till you make it, actually, where we sort of say, like, even if you don't feel like it, get out there, smile at people, interact with people, because it starts giving your body the feedback and your brain the feedback that, to reverse what it's trying to do. We always talk about in our practice, I often talk about, like, depression and anger are very seductive feelings. So they suck you in, they make you do things that actually feed the depression. So you have to push back to kind of get past it, because depression will make you do things that actually sustains the depression. So we want to do things that reverses that. I don't know, Sonia, if you wanted to add.
But waves of depression comes. That's why I asked this question. We fake to be happy, but in the subconscious part, there are waves of depression. That's why I asked, is it depression or is it need medical treatment?
So, this is actually a really good question, because is how people report depression is really related to multiple factors. And so when you say fake depression or real depression, there's not enough information we know on what is fake. So for example, when I treat adolescents, and again, that's where my background comes in, is the parents don't report the depression. So if the parents are reporting the depression and the teenager saying, I'm not depressed, then they are not depressed. But if the parents are not reporting the depression and the teenagers reporting the depression, then they are depression. So I want to say is some people are not able to report their depression. Is that what you're saying, fake depression, or?
No. I mean to say fake happiness. Usually the elderly people who have lost their partner, they try to be happy in the existing circumstances, but there are waves of impulse of negative thinking. So I thought, does it need treatment, medical, by medicine, or just by behavior or moral support?
I would say behavior.
Yeah. So there's the specific context of, and this kind of gets a little bit to Dr. Gupta's question too, is you might be talking about bereavement or complicated grief. So these are all kind of dimensions of that experience. It's hard to know just from that example whether medication will or will not be helpful. And certainly I would not be the expert, and if Sonia says behavior, then let's go with that. But certainly when you're coping with major life stressors, it's definitely helpful to get psychotherapy, because there's a way of it can help change the lens with which you are viewing the challenges. And so one of the things that CBT can help with is changing how you cope with something, improving coping that is proactive coping. A lot of times we revert to avoidant coping, and sort of putting a happy face on when you're feeling sad is kind of an avoidant coping, because you want people to sort of think that you're happy. But what it can help you do is start living the new life following a major loss, whether it's a partner, whether it's a job, whether it's any other life stressors. A CBT can help, or any psychotherapy can really be helpful in helping with the coping of that. And that is not specific to depression. You may just be feeling out of sorts, or maybe feeling just, flat-footed by some life event that happens, and it may not rise to the level of a clinical depression. But CBT can help with the full spectrum of distress. And in fact, CBT can also help if things are going well, but you want to build your resilience and build your coping. It's a behavioral approach. So it doesn't have, the problem could be, I'm already feeling pretty good about my life, but I really want to, I have this ambition, I want to figure out how to get there. Then the CBT strategies can help with that too. I see
Thank you,
there's a lot of
doctor.
conversation on the chat, so I'm guessing somebody's.
Hi, can I ask a question? When a patient is at home with family care and starts becoming aggressive and difficult to manage, how does the family or who decides to move him to institutional care?
So I think you had sent me that message, and I had actually accidentally indicated to someone else. So what happens is, with regards to behavior, is you do need to have sort of competency. And for whatever reason is the courts or the law has decided that the people who can do that, a competency is a psychiatrist. And so a psychiatric assessment is the minimum or the starting point from where you can get some help with moving them due to that. And it could be because the psychiatrist also will be able to determine whether, we can just treat it and then move on from there.
So that will be by referral to psychiatrist through primary care.
So for example, is you can just go to any psychiatrist, to be honest with you. You can talk to your primary care physician in order to do that. And the primary care physician of the patient is who you have to talk to, is to get that referral. And sometimes the primary care physician is aware of the social complexity. Sometimes, for example, they can put a referral to their local social worker. Some places have that. And the social worker can also do an assessment and then move it on to a different level, because, there are a lot of medical social workers who can work with that.
What happens when the patient refuses to go to the institutional care?
In order to send someone to an institutional care, you need to have competency, and a competency is only done by a psychiatrist. Only the psychiatrist can decide that, and once they're decided, they're not able to make consent. Nobody can take anyone into the institutions. The laws have completely protect the people, so they can run around. That's why we have our homeless people around, is because before they were in institutions, now they are around, and they're not able to sustain due to their behaviors or keep a job.
All right, great thoughts.
There's one more question that was sent to me, but I think Sonia is a better person to address it if people have a minute to.
Sure.
Okay.
Somebody asked me if a family member has been on an antidepressant, escitalopram for anxiety or depression, is it possible to get off, and how? And
I did respond to them, but I may have responded.
Okay.
Yeah,
Okay.
Whoever asked me, did you get my answer? Because I think with the chat page, I ended up sending it to one person without really realizing it.
No, it was sent to me individually, and I suggested I ask you. So if you've addressed it, then that's.
I think I have. I'm not sure if I did, or I'm happy to.
Yeah,
So
and then somebody also asked for our contact information, and I put that in the chat.
Okay,
as well.
Rena P did ask me. Okay, so can I just sort of talk a little bit about that briefly? So Rena asked a question on if someone's been on long-term Celexa or citalopram, is how do you actually discontinue that if the person wants to? And so that is one of those medications which actually is not that easy to go off. Not because they've been long-term, but because of the nature of the medication or their half-life. So there's something called serotonin discontinuation syndrome. So because of that, I'm just putting it in the chat. Sorry, I'm not the best typist, but it's a serotonin discontinuation syndrome. And So what it is it has to very slowly be tapered, in a systematic way. And then after the last dose, for up to 6 weeks, you have to monitor the person for any signs, which would be the biggest concerning sign is actually suicidal ideation. So but there's also fatigue and there's agitation. And I want to say it is limited. And as long as they're monitored, so in general, never discontinue anyone from a medication like Celexa or citalopram on a Friday. That would not be a good idea. I hope that's helpful.
Thank you very much. I think we had a great session. One last question, Dr. Ramachandran, you had typed a question you want to ask. I think you're muted.
Yeah.
Dr. Trivedi, when you talked about possible risk factors, you mentioned, your slide mentioned substance abuse. And you often hear people with a history of either, alcohol addiction or drug addiction. They talk about, oh, they do this because they're depressed. And I often wonder, do they do that because they're depressed, or they're depressed because they're doing all of this?
Yes.
Yes to both.
Yes to both. So I think that's a pretty broad question. I think there is, and Sonia, please jump in because you're a lot more active in the practice than I am right now. But there's the drug use, whether it's substance use disorders or, the illicit drugs or things like alcohol, which are legal, or marijuana, which is legal. There is an indication that it is a way of coping, right? And that's actually one of the avoidant coping strategies we talk about. But there is also some evidence, there's evidence that the prolonged use of those can actually make people prone to mental health conditions. So if people started doing the drugs, just kind of experimenting in their teenage or whatever the scenario might be, prolonged use does have a sustained changes to the biochemical or the biochemistry. So it's it could be both. And there is this sort of idea of a substance use. And then there was another question about in the chat that I also wanted to address in the same way, which is, people sort of answer some 0 on PHQ and then, but they then talk 45 minutes. I think a lot of it kind of sometimes comes down to, and we all know this, is to listening what they're saying, but listening what they're not saying, right? And so it could be that when people bring up the issue of substance use issues, what are they saying that they need help with? And what are they not saying that you think they need help with as well? And then we have to be prepared for being present in that spaces. So one of the techniques, especially for substance use disorder, is motivational interviewing, is their willingness to make the changes that they think they need to make, or you may think they need to make, and how willing they are to make those behavioral changes. I hope that helps.
Thank you.
Yeah.
Enjoyed your talk. Very good.
Thank you very much. From Appio family, I want to express my profound gratitude. I know this is already past 15 minutes, and all the 24 participants, they are glued to this talk. That tells me the biggest testimonial. Yeah. So if anybody need any slides, please send email to president@appio.org, and I will share the slides and any links you need. And again, thank you very much, everybody. I hope everybody.
No, it was a great pleasure. And these questions, we tried to keep enough space for those questions, because that's really what generates the learning process, since we are talking about that.
Absolutely.
All right.
Thank you very much for inviting me.
I'll send my slides to you. All right.
Absolutely.
Bye-bye. Good night.
Good night.